Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This program is presented by Medscape Education Global.
Hello, I'm Harpreet Bajaj. I'm an endocrinologist and a researcher in Canada. I'm here to take you through this program, which is titled Novel Biological Approaches for Enhanced Obesity and Diabetes Management. What's coming up next? I have with me two eminent researchers. Kirsi Pietiläinen is a professor in clinical metabolism at Obesity Research Unit in the University of Helsinki in Finland. And Domenica Rubino is here. She's the director of Washington Center for Weight Management and Research in Virginia in the United States. So today we're going to talk through some of the serious and chronic nature of both obesity and type 2 diabetes and focus on what's coming up next in terms of the pipeline of biological medications, in terms of incretins and other non-incretin medications as well. So Domenica, could you just lay the background and tell us more about what is this, why there is a need for better risk control in patients with obesity and type 2 diabetes?
Sure. So one of the things I think that's important, and as we've been in this field for a really long time now, is really realizing the impact of obesity, right? And we need to focus on the health risks associated with obesity. And it's not as simple as just weight loss, right? It's about taking care of the whole person and reducing their cardiovascular risk, their longevity. And in fact, you know, we understand now that you can actually lose years of your life expectancy based on having a high BMI of 40 to 50 kilos per meter squared compared to someone who's considered normal BMI of less than 25. So really the focus for all of us and the focus of the development of these medications is to improve quality of life and life expectancy. So, you know, as we're talking about these obesity-related complications, we have to understand that obesity affects many different systems, right? So the development of medications is often not just to target weight, but to get specific outcomes for those individual complications. So we have metabolic disease, of which we've heard a lot about in terms of diabetes and metabolic liver disease. We have vascular diseases, of which patients with obesity are really prone to develop and suffer from. But we also have mechanical effects like respiratory distress, obesity-related sleep apnea. A lot of our patients have sleep apnea, which actually incurs quite a bit of cardiometabolic risk. We can't forget mental health. That's greatly affected by people with obesity. They're at risk for depression, and there's a bidirectional relationship between obesity and depression. And also many folks suffer from anxiety as well. So there's also additional risks. There's cancer risks of many different cancers have been associated with obesity. But the other thing that, and we'll talk about this a little bit, is musculoskeletal, both from weight loss potentially impacting, right? We want people to be functioning better. At the same time, right, we want our patients to function better and to feel better in their quality of life. I think the other thing really to understand too is type 2 diabetes. This number is increasing because of the rate of increase in obesity as well. And so unfortunately, certain countries that are of lower and middle income are actually at much greater risk, right? So it's really understanding how can we help people with diabetes and also how can we prevent diabetes. The other thing I think is important maybe for our audience to sort of refresh and understand is that the impaired adipose tissue, its function leads to increased inflammation, change in adipokines and metabolites, but really some of these organs that we see these complications actually have deposits, have ectopic deposits of abnormal adipose tissue, leading to insulin resistance both systemically as well as at the level of the organ. And so we're understanding more about those mechanisms and how they increase the risk of renal metabolic disease and how they work together with type 2 diabetes, right? So those are really our targets. We know that when a person loses weight, this improves those comorbidities. We don't need as much weight loss for some obesity complications, right? So we know if our patients can get 10% weight loss, we can see some improvements in blood sugar regulation and hypertension, et cetera. But then there are some disease states that actually require more, 10 to 20% for liver function abnormalities, reflux, et cetera. So we're really focusing on these individual obesity-related complications.
Thanks, Domenica. That was very clear. Clearly, obesity and type 2 diabetes are big and a growing global problem, which could undoubtedly be improved by significant and sustained weight loss. I'll show you a table from the recent Obesity Canada guideline, not just because I'm from Canada, but because this is the most recent one that was just updated last month. But if you look through on the columns, it has current agents, so liraglutide is there, semaglutide, tirzepatide. And if you look at the rows and how they structured those, first it's cardiometabolic complications and the effects on those, and then mechanical complications, specifically obstructive sleep apnea or osteoarthritis. And then patient-reported outcomes, which are very important as well, are addressed in this kind of evidence, where the evidence lies and where there are gaps in the evidence as well. And then the last row is the average weight loss, how much is reduced, is there as well. As you can see in that row, that placebo-controlled weight loss or placebo-subtracted weight loss is in the region of 3 to 18% with the currently approved medications that we do have at present. And some of these agents are also impacting or improving comorbidities like type 2 diabetes, MASH, ASCVD, sleep apnea, and others as well. But there are many gaps that still exist in this paradigm that we live in, and maybe therapies for the future could address some of these clinical gaps that exist even more. If we were to subdivide those gaps, I would say the magnitude of weight loss is one. Maybe the quality of weight loss, lean mass versus fat mass, is important to differentiate, and the functioning of that is even more important. And also, of course, the effect on glucose control in people with diabetes or people with prediabetes or no diabetes as well is important. And then outcomes in terms of cardiovascular outcomes, but also liver comorbidities, I think, are important paradigms which will continue to influence our therapeutic choices in the future as we move on as well.
But I think on that guideline, what's important to remember is, we're all very focused on GLP and GIP, GLP, and all the new stuff, but you can't forget about the old drugs, because the old drugs are still, for many people, what they can access, depending on affordability, and they are effective.
And that's an excellent point. And some of those older drugs are also oral in nature,
correct,
which is sometimes an additional hindrance.
More appealing to a patient, maybe easier, et cetera. So we have to understand we have quite a spectrum of what we can use.
One important point as well is that whenever we help our patients lose weight, there will be 200 different disease states that are getting better because of that, and because of the lifestyle change, because of better nutrition, physical activity. We will have improvement to many other things as well as those listed comorbidities.
Right.
I think that the first sign of an effective drug is that the food noise gets down.
I think that's right.
That's a very big relief for our patients. So when they get this effect, they are already very pleased.
Yeah.
So I think the point you make is very important. Maintenance is very difficult.
Yeah.
And so that first step that Kirsty says is really critical, because what happens is if you turn the volume of that down, they start using all the skills that now actually work, that they have been basically battling in a large way in terms of the endocrine response, right?
And that's very important. But getting back to newer therapies as we move forward and that are in clinical development, Kirsty, and I'll put this to you. How are we doing in terms of weight loss and addressing some of those comorbidities that you mentioned as such?
So to answer your question, maybe I would go through the appetite system a little bit closer again, because appetite is something that we are really trying to suppress with the new medications. Of course, we are also trying to do the organ protection and improvement of health and health-related quality of life. But appetite is really the key that the target is.
In the natural biology of weight regulation, we know that there are many hormones feeding into the homeostatic regulation of food intake. This includes the hunger hormone ghrelin, and there are many satiety hormones at play: GLP-1, GIP, amylin, glucagon, CCK, PYY, leptin, and others. Several of these hormones also work on the hedonic regulation of appetite, which also happens in the brain. This is the wanting and liking of food and cravings mediated by dopamine and opioid release.
So appetite, of course, is very complex, as obesity as a disease is very complex. So appetite never is dependent on one molecule, one signaling route. So now that what we are having is that, well, we are having two signaling routes that we are covering with the current medications from the gut. If we are thinking about GLP-1 and GIP, those are the incretins that we cover currently. But there are many more drugs in the pipeline, and many of them actually have the GLP-1 base added with other molecules. GIP agonist, GIP antagonist, glucagon, dual or triple agonists, amylin, and other such molecules. So it's a very interesting era.
Even with the new drugs, I hear patients say, well, now I don't need to make lifestyle changes, right? But actually, in reality, they do. Lifestyle management does not go away.
No.
We're actually just changing it and kind of helping people work with it.
Yeah, but nutritionists, dietists, physiotherapists,
right.
and our own skills as medical doctors in this field is still very important.
Yeah,
very important points. Talking about all these new molecules in clinical trials, how has the magnitude of weight loss been seen? Could you maybe take us through that?
So today we are really focusing on obesity. So let's look at the magnitude of weight loss of these new combinations.
So first, let's talk about the combo of GLP-1 and amylin. We're very familiar with the effects of GLP-1 already, as a satiety hormone, delays gastric emptying, and has glycemic benefits. Amylin is a hormone co-secreted with insulin from pancreatic beta cells in response to food intake. It works to regulate postprandial glucagon secretion, reduce appetite, and slow gastric emptying. Amylin reduces appetite by targeting homeostatic appetite regulation in the brain and may also target areas involved in hedonic aspects of weight regulation.
Indeed, CagriSema, which is a combination of cagrilintide, which is an amylin agonist, and GLP-1 agonist semaglutide. So REDEFINE 1 and REDEFINE 2 studies are such that have been published already. These are phase 3 trials. And that's where we saw that amylin alone, cagrilintide alone, produced about 12% weight loss. Semaglutide alone, 15 to 16% weight loss, and then CagriSema combination, depending on whether we looked at the ITT population or the completers, over 20%, as much as 23% weight loss. So this is really like now big weight losses that we are seeing with this combination drug. And the REDEFINE 2 is a study with type 2 diabetes, the figures that I showed were for obesity patients only. And with REDEFINE 2, where we have type 2 diabetes, the effect size is a little smaller, but it's very significant. The weight loss is up to 16%. And it's much, much better than with the placebo treatment. Also, amycretin, that's another compound where the effect is through GLP-1 receptor agonism and amylin agonism. In amycretin, this is one molecule, whereas in CagriSema, there were two molecules. So the phase 1b to 2a study of the amycretin showed that over 20% of weight loss was achieved with a 36 weeks time period. And interestingly, in many of these new compounds, what you can see is that within 1 year mark, the weight loss has actually not even plateaued yet. So we are speaking for the very long treatment periods, even to get to the maximum weight loss point.
That's true.
So that's something that I think we are seeing with these new combinations.
I think that's actually important for physicians to understand, right? So you don't necessarily need to go to the highest dose immediately. You just need to work with tolerance.
That's a very, very important point. Another combination which we are having is GLP-1 GIP agonism.
Now, we are also well familiar with dual GLP-GIP agonism in the form of tirzepatide, which is already approved for treatment of type 2 diabetes as well as obesity with or without diabetes in many countries.
The SURPASS CVOT study has been just presented. So here the design was such that there was tirzepatide and dulaglutide, so two active drugs and a comparison of those. So with tirzepatide there was more weight loss than with dulaglutide, so around 12% in tirzepatide group and around 5% with dulaglutide. What was your experience with this study?
And it's a cardiovascular outcome trial where new drugs are added in. It's allowed as per standard of care, and it's a long-term study as well with more than 3 years of exposure. And so with that long-term weight reduction being better with tirzepatide versus dulaglutide by about 7%, I think that's quite promising and encouraging over time.
That is indeed true. So with that, Harpreet, what have we seen with the new agents targeting glucagon receptor this time in combination with GLP-1?
So what happens if we approach dual targets of GLP-1 and glucagon? Well, with GLP-1 agonism, we get robust glycemic control, satiety, and reduction in cravings. With glucagon agonism, we have an effect to induce satiety, potentially to increase energy expenditure, catabolic actions of glucagon in the liver, increasing hepatic glucose production, and also stimulation of lipid oxidation. So with a balanced dual GLP-1 glucagon agonist approach, we might expect to see weight loss and potentially a benefit to glycemia.
Yeah, it's been interesting. In endocrinology, we always thought of glucagon. We should not, have a glucagon agonist because it's probably not a good idea because it'll raise the sugars, but we haven't found that. In fact, we've seen in phase 3 trial with this drug called mazdutide. This was published recently in New England Journal of Medicine, and this drug is actually approved in China. So this was a Chinese study that was done, and based on this, it was recently approved as well. In this trial, they showed a weight loss with a higher dose of about 14% at 48 weeks, which is quite remarkable in that Asian population as such as well. And then, it's still not reached the nadir or the plateau phase at that, as you were mentioning as well. So that's quite promising. There are other glucagon agonist agents that are in development. One is survodutide, which we've seen phase 2 data for. Phase 3 is ongoing. We don't have the data. But in the phase 2 studies, there was, depending on the dose, there was a greater reduction in weight that was seen. And again, the weight, average weight is still going down even at the end of the trial. So it'll be interesting to see what the phase 3 shows.
So now let's look at the triple agonist approach with GLP-1, glucagon, and GIP agonism. So we have appetite reduction afforded by all three, glycemic improvements with GLP-1 and GIP, potential increase in energy expenditure and hepatic lipid metabolism benefits with glucagon, and potential benefits of GIP in adipose tissue.
And then, of course, we've had this retatrutide, which is the triple agonist. And with that, we've come, at least in the phase 2 trial, almost 25% weight reduction, almost achieving or getting to the level of what we see with the gastric bypass surgery as well. So that's quite promising. And of course, phase 3 studies are ongoing and should be reporting in the next year with this molecule, the triple agonist retatrutide, which looks quite promising.
You know, I think too, for people who are listening to this who are not familiar with it, it's important to understand that the GLP or the GIP-GLP component is actually important, right? Because that's thought to mitigate potential hyperglycemia from glucagon, but we're not going to see glucagon agonism on its own, right? I don't think so.
And that's an excellent point as such. So Dominica, passing on back to you, you know, there's other agents in addition to what we've spoken about. Could you share some data around those?
Now, we are also well familiar with dual GLP-GIP agonism. Now, what do you think would happen if we used an approach including GIP antagonism?
So MariTide program, the maridebart cafraglutide, the phase 2 data is interesting. No one really totally agrees on the mechanism, right? It's thought either way to potentiate the GLP-1 effect, whether it's affecting internalization of the receptor. Nobody really knows exactly. So the phase 2 data is very interesting. If you read this paper, it is a very complicated phase 2 trial with all different arms. Fundamentally, there's a couple of key bits that they looked at. They looked at different doses with no dose escalation. And as everybody knows, with these types of medicines, we really do have to dose escalate. Anyone who's been in these trials or used these medicines understands we have to go slowly, but they're trying to find an optimal dose in phase 2. The other thing they looked at is with a slower dose escalation, right? So fundamentally, the molecule, what you see is really significant weight loss at the end of a year, right? So up to 19.9%, and in those subjects or participants with type 2 diabetes, you see some impressive weight loss with type 2 in patients with type 2, and we know that that's a group that often we have resistance to weight loss, even though I think we haven't totally explained why, right? And we have to explain that to our patients all the time. Those who have type 2 diabetes, you're not going to see the same level of weight loss. But the other thing they found in this trial that was very important, which isn't a surprise to people who work with these molecules all the time, is you need to dose escalate. And the slower you go, the more you tolerate these medicines.
Yeah, and you know, I think the other interesting part about this MariTide is the interval of dosing is every 4 weeks or every 8 weeks.
It's a once-a-month injection.
Which is much less than what we have currently.
So let's see, what else do we got? So the BELIEVE study was looking at bimagrumab in combination with semaglutide. So bimagrumab is inhibiting the inhibition on muscle, which is resulting in muscle growth and actually decreased fat deposition. So the idea is, can we mitigate some of the lean loss that we see in patients? And so what we found was the combination of bimagrumab plus semaglutide, we did see a very significant amount of weight loss. So we saw greater weight loss than in the semaglutide arm alone. We saw about 20% in the highest combination dose, compared to the average weight loss of about 14% with semaglutide. And bimagrumab alone, we did see actually weight loss as well. And I think we're going to talk about the muscle results after. But in terms of adverse side effects, this molecule does add to some additional new side effects. There was more diarrhea in the group with bimagrumab, and there was also a fair amount of muscle spasm. So that was important, and acne. So people complained, adults complained of onset of acne, and possibly a little bit more fatigue. So we're going to really be sort of watching this space in terms of this molecule because it's really new and actually quite interesting.
Yeah, importantly, there was no increase in CK values.
Yeah, which is interesting, isn't it? You would have expected to see something.
Right.
So we'll see. And then one of the last ones is dapiglutide, which is actually a new study looking at a combination GLP-1, GLP-2 agonist, which is kind of new to the front. And there's a consideration that GLP-2 receptor agonism is important for intestinal inflammation and what's going on in terms of that. So there's still a lot to be understood about how that combination molecule is working. It's been associated with weight loss and GI side effects, but that's about all we know right now. So a lot of new data, and that's just us focusing on weight loss. So Harpreet, you want to comment on how do these things work in terms of working with glucose control?
Yeah, and it has to be a comprehensive approach when we have that clinical situation when we are treating not just glucose, but also weight control, and so comprehensive in that respect. And we've had very promising data with these dual agonists and triple agonists that I'll share. First, starting with the amylin analogs, so CagriSema, there was a REDEFINE 2 trial with obesity and in people with type 2 diabetes as well, where the A1C reduction was 1.8% for the combination, which is quite remarkable as well. Now, there are other amylin analogs that are in development, and we'll see. You mentioned Kersey amycretin, and so we'll see how that pans out in terms of A1C reduction in people with type 2 diabetes. About the SURPASS-CVOT, which was presented at the EASD, this is, again, a comparative trial, so it's not against placebo, but an active comparator with dulaglutide. And there's a 0.8% benefit in terms of glucose control with tirzepatide versus dulaglutide, which is quite remarkable in that sense. And also, again, over a prolonged period in that trial that was seen. In terms of targeting glucagon and that question of whether that changes, we don't have the complete answers, but I mentioned mazdutide, and in that Chinese trial and in a meta-analysis, they've shown an A1C reduction of about 1.3% overall, which is quite good. And then with the triple agonist, retatrutide, there was, again, a reduction of about 2% on the highest dose, which was quite remarkable in that phase 2 trial. Of course, phase 3s are still pending. The meritide, and I'll not butcher the name, but I'll just stick to meritide as such, which also has shown similarly about 2 to 2.2% A1C reduction in that phase 2 trial, which was released. And then finally, about this bimagrumab, the jury is still out, but at least the data that we have from the BELIEVE study suggests there may be some benefit. Of course, this study was not just in people with diabetes, so we'll have to see what future studies show in people with diabetes in terms of A1C reduction. So we've talked about some of these, and we've had some positive cardiovascular benefits that have come across, first with semaglutide and now with SURPASS-CVOT in terms of cardiovascular risk reduction. Kersey, could you talk through some of the cardiovascular comorbidities, please?
Yes, this is very important, of course, and we know the good results from select studies where semaglutide was a monotherapy. So now the SURPASS-CVOT study is published, but how would you comment this result?
Yeah, so this was a pre-specified study design where both dulaglutide, which has already been proven to be cardioprotective in REWIND trial, as you remember, was compared against tirzepatide. And in pre-specified analysis, comparing SURPASS-CVOT with the REWIND trial, And if you look at tirzepatide versus a putative placebo from the REWIND trial, you see a benefit in terms of cardiovascular MACE-3 endpoint. So about a 25% relative risk reduction in terms of MACE-3, and a benefit on death endpoint from that 3-point MACE as well. I think what the interpretation of this study overall is that both tirzepatide and dulaglutide are cardioprotective when you compare it to placebo. That would be the right interpretation.
And of course, we need to be careful in looking at cardiovascular health from the organ perspective, like heart events, stroke events, perhaps sex differences. So a future will show us how those results look like.
Yeah, excellent point. Well, what have we seen in terms of blood pressure and LDL, Kirsty?
Well, for lipids, whenever we do obesity research, so what we see always, this is with lifestyle, and this is especially with these GLP-1 based new molecules now, where we see that the triglyceride component from the lipid panel is the one that goes down very significantly. That is likely because liver fat is decreased heavily and very soon after, or even a small amount of weight loss, and VLDL production is decreased. Therefore, when we measure triglycerides, that's the component that we see as being reduced. There's a lot less effect for HDL and LDL compartments, but about the bimagrumab and that combined with semaglutide, there's maybe a little change compared to the other agents?
Yeah, I mean, I think the bigger difference that people are a little bit concerned about, and we have to understand more about it, is that when you combined bimagrumab with semaglutide compared to semaglutide alone, what you saw was actually you didn't see the improvement in LDL, right, that you see normally with semaglutide. And so now you see, I guess, a relative increase. Bimagrumab alone increases LDL, and the combination, you don't see the improvement in LDL. So people are just trying to figure it out, basically. I think it's early days, so we have to see more data, basically.
Okay, how about the blood pressure, Kirsty?
Yeah, blood pressure is improved usually a lot. Up to 10 millimeters of mercury, systolic blood pressure, diastolic a little less. But this is part of the beneficial cardiovascular effects. However, many, if not all, of the GLP-1 based medications increase heart rate a little bit. But still, when we take a look at the hard outcomes, the cardiovascular outcomes, that's what then counts. And of course, when we are treating our patients, we need to make sure that they don't have too much antihypertensive medications.
Because we often have to reduce the antihypertensives because this is like a glucose lowering agent that reduces blood pressure and LDL and triglycerides as such, right? So coming back to that quickly, and we are running out of time, about that lean body mass and changes that we've seen in terms of this interesting molecule, bimagrumab. Maybe, Domenica, do you want to talk through that?
Absolutely. So we talked about the mechanism that, what we get concerned about is that weight loss interventions, that results in a loss of muscle and fat. We want the fat, we don't want the muscle, right? And we understand that whenever you calorie restrict, regardless of diet and lifestyle intervention, bariatric surgery, or these medications, you're going to get a 25 to 40% reduction in lean mass. That includes organs, not just skeletal muscle. But so we're trying to understand, can you target the regulatory pathways? And in the BELIEVE trial, what they saw is the bimagrumab group alone, you saw an increase in total lean body mass. In the semaglutide group alone, you actually saw a loss of up to 7.9% of lean body mass. And when you combine them, that actually got reduced to about 2.6% lower. So there was a mitigation of that lean body mass. Now, this trial didn't have functional data, or at least it hasn't been reported. So that will be what actually is really important. Do you see functional differences when you're hanging on to that? So the last of all, we were starting to talk about liver and liver comorbidities, and lots of our patients have metabolic-associated steatohepatitis and liver disease. So Harpreet, you want to comment on these new combinations?
Yeah, absolutely. I'll just, there's a lot of data that is emerging. I'll just focus on agents that have glucagon agonism, because we know that glucagon has opposite effects to insulin on the liver, and specifically reducing liver fat and then reducing liver inflammation and hepatitis as such, right? So there's emerging data, and these are early studies that have been shared, that any of these compounds, the dual agonist mazdutide, survodutide, as well as the triple agent, the retatrutide, which has glucagon agonism as part of the mechanism as such, may have additional beneficial effects on reducing liver fat. More than 30% reduced in all of these studies in a majority of the participants in these trials, which is amazing to see. And of course, more phase 3 data is ongoing, and it'll be interesting to see what that shows in the long term in terms of liver MASH fibrosis, as well as long-term liver comorbidities as well. So I'll just wrap up with the safety endpoints as well. We've covered some of them for bimagrumab, but if you think about some of the GLP-1 side effects that we are familiar with, any of these dual and triple agonists that we talk about, most common adverse effects with these are similar in a way. So adverse events on the GI tract, so nausea, vomiting, diarrhea, and constipation, which are temporary, which over time do get better, and slower titration, as well as education around reducing fat intake or fried food intake may help as well. And most of these are mild to moderate to begin with, and it needs a little hand-holding in a way for your patient to continue on with the medications while getting through those kind of nuisance side effects as such. And they'll be similar with the emerging pharmacotherapy. Of course, there's a lot of future research that needs to be done in terms of type 2 diabetes. As an endocrinologist, I can think there's a lot of questions that are out there, whether these dual triple agonists, when we are achieving A1Cs of 5.5, are they actually changing the pathophysiology of type 2 diabetes as well? And are they going to delay insulin initiation and delay the progression of type 2 diabetes as such? And more data is needed in my mind in that respect. So with that, I'll just summarize what we've discussed, and we've discussed a lot, and thanks for sharing your wealth of knowledge, both Kirsty and Dominika. I'll just say that we have a new armamentarium of medications that are in clinical development, which are even more promising than the current slew of medications that we have, which have gained a lot of traction on social media. So there's a lot of interest in those molecules, not just with the magnitude of weight loss, but also on comorbidities like cardiovascular and liver-related comorbidities as well. And hopefully we'll be able to tease those out in the future and tailor therapies to the individual that we're treating with, that we're treating in front of us as well, so that we can actually achieve the precision kind of medicine that we all need to do with individualized therapy. So Kirsty and Dominika, thank you so much for this great discussion. I really enjoyed it. So thank you also, every one of you, for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.
This program was presented by Medscape Education Global.